Good morning, everybody. I welcome you to the session about Arthritis Nanomedicine. And the first speaker is my dear friend, Dr. Stephanie Stanford. She will talk about rheumatoid arthritis, unmet medical needs, and how nanomedicine can help.
Hi, everyone. I'm Stephanie Stanford, and I first of all like to thank the organizers for putting on this great conference. This is my first time, and thank Massimo Bottini for the invitation here. So I'm just going to give you a brief introduction to rheumatoid arthritis. So rheumatoid arthritis is a common systemic autoimmune disease. It's actually the third most common arthritis after osteoarthritis and gout. And it's very prevalent. It affects about 0.5 to 1% of the worldwide population. It affects both males and females, although it occurs at a higher frequency in females, and it's not yet clear why. That's an area under investigation. However, it does remit during pregnancy. Now, RA is really a terrible disease because it's quite debilitating. So as you can see in some of these pictures that I'll show, it causes debilitating joint deformations and leads to a lot of pain and dramatically affects a patient's quality of life. Interestingly, RA decreases lifespan when not treated, and this is due to increased risk of cardiovascular disease or pulmonary complications and also to increased risk of infections. Now you can just see here some data from several papers showing a study that the increased risk of infection actually occurs in multiple different countries. And you can see here a graph that really shows the increased risk of congestive heart failure that occurs in RA. If you follow a study that was done over time, patients with RA have a dramatically increased risk of cardiovascular disease compared to non-RA. So RA is a very complex disease, and how it starts can sometimes be a mystery. It involves almost all aspects of the immune system and also has a heavy component of local cells that are in the joint. So RA is definitely driven by innate immune cells such as macrophages, neutrophils, mast cells, and dendritic cells, which are often the initiators of the disease. There's a heavy adaptive immune cell component, so T cells and B cells both play a role. And there are non-immunological cells located in the joint, such as fibroblasts-like synoviocytes, endothelial cells, and of course chondrocytes in the cartilage play a large role in this disease. Now what happens in RA is that you get hyperplasia or thickening of the synovium. So the synovium is this capsule that you can see here. This is the joint capsule. This is the bone and the articular cartilage on the surface of the bone, the joint capsule, and the synoviocytes in a normal joint. They form this lining that protects the joint. They secrete lubricants and they provide structure to the joint. The synovium during RA develops synovitis, so you can see this thickening here it becomes full of immune cells and also overgrown synoviocytes. Now, during synovitis, there are cytokines that are produced by the fibroblast-like synoviocytes which promote angiogenesis to the joint. And actually, we'll talk later that there are some aspects of RA that are very similar to what happens in cancer and in tumors. So just like tumors promote angiogenesis to the tumor, also in RA, the synoviocytes promote angiogenesis to the joint. Now, this increased activation of endothelial cells also helps to recruit immune cells to the joint because the endothelial cells upregulate the expression of adhesion molecules, which help the immune cells to bind and then extravasate to the joint. Now, during RA, the synovium proliferates and grows out of control, and it forms a tissue called panis. Panis is mostly comprised of fibroblast-like synoviocytes, but also neutrophils and macrophages and other immune cells. And the panis has some similarities to a tumor. It actually becomes invasive and invades over into the cartilage and starts chewing away the cartilage and erodes bone. And fibroblast-like synoviocytes are one of the key drivers of the panis. So you can see here what happens in RA in a normal joint. You have the joint capsule here. In an early RA, you get migration of first innate immune cells, macrophages, and neutrophils, but then the recruitment of T cells and B cells, and you can start seeing this synoviocyte accumulation and growth here. And in late RA, this synoviocytes really proliferate, and they form this panis structure, which is synoviocytes plus immune cells, and they start to they start to degrade the cartilage, and then they reach into the bone and start degrading the bone. Now, why RA occurs is a combination of many factors. Of course, there are genetic and environmental factors. So there are several genetic factors, such, of course, the MHC molecule and also another gene, PTPN22, that play a big role in the development of RA. But, of course, there are other post-genetic factors, such as epigenetic modifications, environment. For example, smoking is a very high risk factor for RA. Possible exposure to infections, all that area is still under investigation. And, of course, citrullination of peptides, which is actually often driven by smoking. These events can activate the innate immune cells, which are in the periphery, but also they can activate fibroblasts like synovitis as well, particularly citrullination. This then causes migration of the innate immune cells to lymph nodes, where they then stimulate T cells and B cells, which then migrate to the joint. Then the T cells and B cells produce cytokines, and they also, which cause inflammation, and they also produce, the B cells produce autoantibodies. This then leads to joint damage. Now, cytokines play a huge role in the inflammation that occurs in rheumatoid arthritis, and that's why they've been really the topic of developing therapeutics. So almost every therapeutic that's been developed is either immunosuppressant or targets a particular cytokines. Now, in RA, the macrophages and fibroblasts are actually very in close proximity right next to each other in the joint, and they secrete cytokines, but also growth factors, particularly produced by the fibroblasts, which then stimulate each other. On top of that, the T cells are recruited in, and they produce both inflammatory cytokines, such as IL-17, maybe you've heard of Th17 cells, which are pathogenic in RA. They also secrete anti-inflammatory cytokines. Now, I just want to touch a little bit more on the fibroblasts like synovitis, because when I go through the treatment aspect, I'll mention there are no therapies that target these cell types, and they're in the joint playing a large role in the disease. So these are mesenchymal cells. They're not immune cells. And normally, they support the extracellular matrix by providing structure and integrity to the joint and secreting lubricants. And they also produce proteases and collagenases, which help break down the extracellular matrix and control its composition. And these cells are actually quite easy to work with in the laboratory because they can be taken directly from patients and cultured about up to 10 passages. So the primary cells can be cultured and are very easy to work with. Now, this figure, I think, really well demonstrates the role of synovicites in RA. They actually take on very many features of tumor cells. So they are, like tumor cells, they are resistant to apoptosis, they overgrow. They are invasive, so not only do they secrete matrix metalloproteases and collagenases, which break down the matrix, but these cells themselves actually invade to the cartilage and break down the cartilage. They secrete pro-growth factors, which help themselves and other immune cells to grow, and they promote angiogenesis to the joint. And as you can see here, they promote pro-inflammatory cytokines, they produce chemokines, which promote inflammation to the joint. And so they really play a primary role in the destruction that happens during rheumatoid arthritis. Now, just to briefly, at the close of this, I'll end on the treatments that are available. So over the last 2 decades, there's been a dramatic improvement in the treatment of RA. So there are quite a few disease-modifying anti-rheumatic drugs called DMARDs, which have really helped the quality of, or the lifespan problem. And so there are several of these that are available, and they can be quite effective in patients. They can increase the lifespan and also dramatically help with disease activity. So the most commonly used ones are methotrexate, which is a general immunosuppressant, and also TNF blockers, which target the TNF cytokine but are also immunosuppressant. And this graph here just shows infliximab, which is a TNF blocker. You can see that it can be dramatically effective in people, but still, it's only effective in about 50% of the patients. So here, when a patient doesn't respond, no longer responds to methotrexate and doesn't respond to TNF, there are some options available. All of these are immunosuppressant. So some of them could be, most of them target different cytokines or some aspect of the immune system, such as IL-6 or TNF co-stimulation. There's a B-cell depleter, is a kinase inhibitor, but actually this is a JAK inhibitor, so this really blocks cytokine signaling, such as IL-6. So it's really somewhat of an anti-IL-6. Now, one problem with these as a backup is that they're usually patients respond less to them than after they've previously been treated with a TNF blocker. And there are really almost no predictors of who's going to respond and who's not right now. Now, what happens if a person doesn't respond to methotrexate, TNF, and some of these other substitution biologics? Could you increase the biologics so that you can make them more effective? Well, combination biologics can work, but they can also cause increased risk of infections. And you can see some info from several studies here that TNF plus anakinra, which is an IL-1RA inhibitor, actually does not increase efficacy, but does increase risk of infections. TNF plus abatacept, which is a T-cell co-stimulation blocker, can cause increased adverse effects and have only minimal effectiveness, and similar to TNF and B-cell depletion. So really, what's needed in RA are possibly some non-immunosuppressive treatments. So all of the treatments that are available right now cause immunosuppression, and about 50% of the patients don't have disease remission. So the treatments work for a while, and then they stop working. And combining multiple biologics has its limitations because this can lead to an unacceptable risk of infections because these are immunosuppressive therapies. So really, the major unmet medical need in RA right now is for novel non-immunosuppressive therapies. And I'd just like to point out that right now there are no treatments that are actually targeted directly to the joint. These are all systemic treatments, which work in the joint, but they cause systemic immunosuppression. And there are no treatments that target non-immunological cells. So there are no treatments targeting fibroblasts like synovitis, and there are no treatments that do anything to the cartilage damage. So this is really just as we begin this discussion, or just skimming the surface of how nanomedicine could help. So perhaps targeting therapies directly to the joint, which of course would increase the effectiveness because you're acting at the site of disease, but also decrease the risk of infection because you're increasing the concentration at a specific site. And of course, targeting therapies to the non-immunological cells which mediate the disease activity, such as fibroblasts like synovitis, and also possibly for therapies that would cause cartilage protection or cartilage repair. And so with that, I'd just like to thank my collaborators my mentor, Dr. Nunzio Bettini, who first brought me into RA, and so Dr. Gary Firestein, who also has been another RA influence in my life, the people in my group who've helped do the work, and of course to Massimo Bottini, who's the person who introduced me to the world of nanomedicine. And I would definitely like to thank the Arthritis National Research Foundation for the grant funding that I've had, and then also for the travel award to come here. And thanks to the CLINAM organizers for organizing this great conference. And with that, I'd be happy to take any questions that you have.
There.
Just a curiosity as a non-MD, more a material science person. I don't know if this is working, but probably you should be. Okay. And I'm sorry, I got late into the talk, so I don't know if you might have asked to this also before. My impression is that RA is actually a systemic disease rather than a localized disease, as it could be osteoarthritis that is more related to the joints, right? So I had the impression that for RA, it's actually better to go for a systemic treatment rather than a localized treatment. So I don't know, can you clarify that for me? And again, this might be a very naive question, but...
Right. Actually, this is not a naive question. This is something that we've discussed. So RA has systemic autoimmune features. However, the majority of the disease activity does occur in the joint. And actually, what gets patients to the hospital is usually the fact that their joints hurt, that they have limited range of motion. Now, I would like to so of course, therapies that would target directly the joint would already make a dramatic impact. They might not solve all the problems. However, I would like to highlight that a lot of the inflammation that occurs is in the joint. So decreasing the inflammation in the joint would have systemic effects as well, likely.
So, very nice talk, Stephanie. I believe that nanomedicine could be very good, and actually there have been a lot of reports, I think with liposomes, that maybe they have corticosteroids and then they accumulate at the site of inflammation. The problem is that all these nanoparticles, they have a very short half-life. So what will be, is there anything trying to deliver an oral nanoparticle that can have an effect in this disease?
Right. Actually, Dr. Bertini and I were just discussing this. Can nanoparticles be made into oral agents? Because, of course, that would be more useful for any disease that you're trying to treat. And actually, since I'm not a material scientist, I won't be able to answer that question, but I was hoping to find out more about this from all of you.
Thank you for this nice overview. In light of what you just told us, it seems remarkable that there are no therapies targeting the fibroblasts like synoviocytes. Could you tell us, are there any particular features, any surface markers, anything that make them stand out? I mean, of course, in the case of intra-articular injection, you are already targeting, in a sense, towards the joint. But could one target specifically those cells as opposed to other normal fibroblasts?
Right. So I'll first comment about the intra-articular injections. While that's currently done as a practice in osteoarthritis, it's not in rheumatoid arthritis. So development of a therapy which requires intra-articular injection is unlikely. Patients are unlikely probably for RA to inject themselves into the joint because that's not a standard of care now. However, in response to your other questions about the fibroblasts like synoviocytes, yes, they have particular surface expression molecules which make them stand out from immune cells. And actually the most validated drug target, which is actually progressing to clinical trials, is cadherin 11. So that's an adhesion molecule that's expressed on synoviocytes. It's also expressed on some endothelial cells and other fibroblasts. And there are currently, that's actually being developed at Roche, I believe, here in Basel right now. So that's a surface marker that's been under a lot of investigation. Our lab has actually shown that the tyrosine phosphatase, which are the genes that we study, PTPRS, which is expressed on the surface of synoviocytes and interacts with proteoglycans in the extracellular matrix, may play a large role. Now, the fibroblasts like synoviocytes, like all mesenchymal cells, they express adhesion molecules and they upregulate them during inflammation. They also express proteoglycans and interact with the extracellular matrix. Okay, thank you very much.
Thank you, Stephanie, for your talk. And we can move on to the second speaker.